Chamber. My name is Matt O'Malley. I am the chairman of the City Council's Committee on Healthy Women, Families, and Communities. We are here today to discuss docket number 1054, which is a hearing to discuss public health disparities in Boston's communities of color. I want to thank my dear colleagues and friends, the co-sponsors of this hearing order, Councilors Ed Flynn and Councilor Kim Janey, for introducing this order and their incredible partnership and leadership on this and so many other issues on the Council. The objective of this hearing is to discuss public health disparities as well as resources and measures that can improve public health outcomes. As chair of the Environment, Sustainability and Parks Committee, as well as this committee, I know that our environmental issues directly link to public health and the well-being of our constituents. We hope this hearing will bring more awareness of the issues, for example, the high exposure of particle pollution, as well as many ways to address social determinants of health, such as food insecurity and housing. Delighted to have our panel, who I will get to in a minute before after the co-sponsors give some opening remarks. Monica Valdez-Lupe, who is the Executive Director of the Boston Public Health Commission. Carolyn Rubin, who is the Assistant Professor of Public Health and Community Medicine at Tufts University, and Dr. Joseph Betancourt, Director of Disparities Center at Mass General Hospital. This is a public hearing. As such, I ask all those in attendance to please silence their cell phones. If conversations have to be had, please take them outside. This is being streamed online. It's broadcast on cable television. And any folks that would like to offer testimony after this panel, please sign up on the sign-up sheet to our left. I told my two colleagues that hopefully we'll be fine, but there is a fire happening right now in West Roxbury that I'm going to monitoring, so if I have to duck out, I will leave it in the capable hands of my colleagues, but I'll be in and out throughout the course of the morning. So we'll begin with Councilor Kim Janey on any opening statements.
Oh, thank you so much. Thank you, Mr. Chair, and I want to thank Councilor Flynn for his leadership and his partnership on this very important hearing. I want to thank our panel for being here and for their good work, all of the city agencies and healthcare partners in our city who are doing amazing work, and certainly all of the advocates that are here. We know that this is an important issue. Through the most recent report of the Boston Health Commission, the Health of Boston, we know from that report that Black and Latino residents, Asian residents, and other racial groups in our city are significantly more likely than their white counterparts to suffer from poor health outcomes. And whether we're looking at asthma, if we're looking at diabetes, we're looking at heart disease, we're looking at cancers, these illnesses impact communities of color in a way that we need to come up with some solutions, which is why I'm glad that we're here at this hearing. We see this across the Commonwealth, but here in our city of Boston, where we have the best hospitals, it's important that we close these gaps. And even when we measure ourselves against other states across the country, even if we appear to do better than some of our other states, it's important that we're closing the gaps between these different racial groups. So I am, again, just thrilled to be here in partnership with my colleague and friend Ed Flynn, and our chair, Matt O'Malley. Thank you so much.
Thank you, Councilor Janey. Councilor Flynn?
Thank you, Councilor O'Malley. And Councilor O'Malley, you've been a strong leader on this important issue for many years, so I want to say thank you for your leadership, and to Councilor Janey and being a co-sponsor of this hearing. Councilor Janey, I've learned a lot from over the last 2 years, especially on this important issue that's impacting communities of color across our city. Thank you to our panelists, Dr. Valdez-Lupe, Dr. Betancourt, and Professor Rubin, for coming here today. And I think I've worked with all three of the panelists on public health issues since I started. I represent, as you know, I represent a large number of immigrants and residents of color in my district, particularly in Chinatown and the South End. I have a large number of Asian, Latinx residents in my district. I also represent probably the most residents living in public housing of any district in the city. I'm in my district every day, and I know that there are unique challenges for these residents in my district in terms of public health. For example, when I'm in Chinatown, where my son went to Josiah Quincy School, and I also went to Don Bosco High School there, I've seen almost every day and noticed that there are many residents, children, dealing with asthma, including our seniors. I've noticed that Chinatown, obviously it's surrounded by 93, it's surrounded by Mass Pike, it's surrounded by South Station Bus Terminal, it's surrounded by South Station train station, and we know it's a major truck route from Maine to Florida, and the residents of Chinatown are inhaling that toxics every day. We also know that Josiah Quincy School is located right next to the Mass Pike, and their playground is almost on top of the Mass Pike. We also know that the upper school is located right there where the basketball court is. We know the Reggie Wong Park, where I see a lot of Asian men and women playing basketball and especially playing volleyball. It's at 93. It's at the Mass Pike. The physical environment itself is not beneficial to these residents' health. In fact, the Union of Concerned Scientists had a report that found Chinatown as the most disproportionately affected neighborhood in terms of traffic pollution in Massachusetts. Asian American residents are exposed to 36% more vehicle pollution than white residents. African American are exposed to 34% more vehicle pollution, and Latino residents to 26% more pollution. Also, the Boston Public Health Commission most recent Health of Boston reports that African American, Asian American, Latino residents of Boston are significantly more likely than white residents to suffer from poor public health outcomes. Public health is critical to a person's well-being, and many factors impact a person's ability to access public health resources. Our communities are more likely to face language barriers when trying to access health care, and they are more likely to face housing displacement that cause more stress and face discrimination. I had the opportunity to attend the Asian Task Force Against Domestic Violence recently, and I had the opportunity to meet with them at their office. And they said to me that their number one concern, their number one priority is language access. In this hearing, I hope that we can hear from the panelists and residents across the city talk about their observations and experiences on public health disparities and discuss ways that we can begin to close the gap on these disparities. I hope that we can discuss ways to better expand language access, data gathering, among other things. I know our hospitals, colleges, and universities are also playing a role. As I mentioned, Tufts Medical Center has a very effective anti-smoking program in Chinatown. The VA is part of the debate. Mass General Hospital, Tufts, Beth Israel, BU Medical Center, all of our colleges, all of our universities and hospitals are playing a role. But I'd love to work with the panelists, I'd love to work with the city, and maybe coordinate our experts to make sure we have one strong voice speaking out in support of public health as it impacts communities of color. I'd love to see us coordinate those services and have, whether it's a task force or have a more structured program where we really focus on communities of color and how we can provide the services, education, to make sure that all of our residents, especially our immigrant community, our communities of color, have that access to public health services. Again, I want to say thank you to Councilor O'Malley. I want to say thank you to Councilor Janey and our panelists for your tremendous work over the years on this important issue. But I'd also like to say thank you to the social service providers, that many are here today, and many do this work every day in our communities. And you know, we're proud of the work that they're doing, and I'd love to hear some of their concerns and how we all can work together to improve public health in the city of Boston. Thank you, Mr. Chairman.
Thank you, Councilor Flynn. We've also been joined by the Council President, District 4 City Councilor Andrea Campbell. Councilor Campbell, to give any opening remarks?
Thank you, Cora. Thank you, Cora.
I just want to just quickly thank Councillor Flynn for your leadership here, and also Councillor O'Malley and Councillor Janey for a hearing that's going to happen later today related to maternal health, and for you guys taking the lead on such an important topic. Thank you to the panelists, all the providers in the room, those who are emailing because they can't come today. Health disparities is such an important topic, one we don't necessarily talk about enough. When talking about systemic inequities, we often focus on, and I know I do, education, housing, but if you are not well and don't have access to the resources to maintain your wellness and overall health, and that doesn't just mean prescriptions and making sure you're treating any diseases, but really preventing them. And then also, how does mental health and all these other things play into it? It's a really significant topic, so I'm really excited to be here to listen, to learn, and of course to lend my support. So thank you again, Councillor Flynn, for your leadership.
Thank you, Madam President. And there, in addition to public testimony, at the conclusion of this panel, we also accept written testimony, which will be shared with the committee. I wanted to thank my neighbor and friend, Sherry Dong, who is the Director of Community Health Improvement Programs at Tufts Medical Center, who's submitted some lengthy testimony detailing some of the work at Tufts in terms of smoking cessation efforts in Chinatown, as well as addressing pediatric asthma disparities. So thank you, Sherry, for your great work, and that will be made available to all members of the council, or the committee and the council. So thank you for that. Thank you, panel, for joining us on this Friday morning. Monica, would you like to start? And I think I've given you your doctorate. I've referred to you as doctor for all these years. You're not actually a doctor, but we appreciate your great work anyway. So
I love the promotions
there you go.
I get from the counselors. So happy Friday. Good morning. And thank you, Chairman O'Malley, for inviting us all to testify and hear from us on all the work that we're doing across the different sectors that we represent. Also want to thank the co-sponsors of today's hearing, Councilors Janey and Councilor Flynn, for your leadership on these issues, and also thank you, Councilor Campbell, for joining us today. So as you know, the Boston Public Health Commission is the local health department for the city of Boston, and we're actively engaged and committed to advancing racial justice and health equity. It's actually one of our 4 priority areas in our new 3-year strategic plan. And at our core, you've all referenced some of the work that we do, but at our core is our mission to protect and to promote the health and well-being of all Boston's residents, especially those who are most vulnerable. You've each referenced the health of Boston, so thank you for taking the time to review the work and the analysis that our team has done from our Research and Evaluation Office, because it is something that we have been paying attention to for nearly 2 decades as the Public Health Commission. And while I'll mention some of the great progress that we've made as a city to address and to attempt to close these gaps, we know that there's a lot of work that we still need to do, and that racial and ethnic health disparities continue to persist despite being in a city like Boston in the shadows of outstanding, globally recognized hospitals and community health centers. At the Commission, we understand that the influence of racism and other exclusionary practices contribute to an unequal distribution of critical health promoting resources among racial and ethnic groups. So social determinants like poverty and a lack of educational and employment opportunities often have their origins in discriminatory laws, policies, and practices that have denied people of color an equal right to earn income and accumulate wealth, own property, gain access to nutritious and affordable foods, quality health care, and receive comprehensive resources that will help them be as healthy as they can possibly be. And so we affirm that health equity is not possible without addressing the issues involving racial justice. Our Office of Health Equity leads our efforts in understanding the needs of our community and planning for improvement, while also implementing everyday practices and principles that will promote health equity in all of our work, both internally and externally. Within the office, since I've returned to Boston, we have convened a Health Equity Advisory Committee. Communities from across the city apply to be part of this cross-cutting committee that advises our nearly 50 different programs. The residents come from different cultures, backgrounds, lived experiences in neighborhoods and planning, development, and implementation of our work at the Health Department. Just this summer, we received 66 applications and for only 12 seats. We're actually introducing the new Health Equity Advisory Committee members at our November 20th board meeting. Through our consortium of professional development, we've developed a nationally recognized training curriculum called the Racial Justice and Health Equity Professional Development Series, or the PDS series. So this is a mandatory training that all new employees at the Boston Public Health Commission are required to attend. It lasts over 2 days. And the goal is to really ensure that all of our staff apply a racial justice and health equity lens to all of our work. Since we launched the trainings, we've trained nearly 1,800 employees in this. Some recent initiatives and developments that I wanted to be sure to highlight is work that we started last year in partnership with Chief Martinez, our Chief for the Health and Human Services Cabinet, and Lori Nelson, who leads the Mayor's Office of Resilience and Racial Equity, to launch a Health Equity in All Policies task force. And this is aimed at building capacity across all city agencies to integrate health and racial equity assessment and decision-making into policy, planning, and institutional processes and procedures in their respective departments. This group was really designed to complement and support Mayor Walsh's Imagine Boston 2030 and other plans, including his resilience plans, which really do focus on the needs of marginalized populations by advancing racial justice and social justice. With our Board of Health, we're currently considering proposed amendments to our tobacco control regulations that would close the mint and menthol loophole. A long legacy of targeted industry marketing, along with the density of retail outlets that sell and advertise menthol products, have led to disproportionate use of these products in our communities of colors. And so through these regulatory changes, the board is aiming to strengthen our efforts to prevent our youth of color in particular from becoming the next generation of smokers, and also to address other health disparities that result from smoking. Also wanted to highlight in the work that we're doing around opioid use disorders that we recently published a data brief entitled Racial and Ethnic Differences in Accessing Substance Use Disorder Treatment following an opioid overdose in Massachusetts and Boston. And through this report, we were able to show that for Black and Latinx residents in Massachusetts, they were 24% and 22% respectively less likely to receive substance use mistreatment after 30 days afterwards being admitted for opioid overdoses as compared to whites. I also wanted to make sure that we've seen progress in the city, and you've each highlighted that there have been persistent racial health inequities, but I don't want to dismiss that we actually have made progress over the years. Between 2006 and 2017, the mortality rate for Black infants in Boston decreased by nearly 36%. Between 2011 and 2017, the teen birth rate decreased by 61% overall, and we saw an even greater rate of decline for teens of color. So for our Black teens, the teen birth rate decreased by 66%, and for Latinx residents, for the Latinas, it decreased by 74%. We also saw progress when we looked at data regarding binge drinking among our Boston high school students, and we saw declines among Asian and Black high school students in particular. Wanted to also share that we're working with our hospitals in this city and with our community stakeholders on their community health needs assessment and community health improvement plans, and I appreciate that each of the counselors have been engaged in that work. And this will be, I think, a vital step in tackling what you raised, Councilor Finn, in terms of how do we better coordinate services and invest resources in the communities that need it the most, especially when there are needs that have been identified and there are solutions that have been identified by collaborating with community partners and community residents. So in closing, again, want to thank you on behalf of our team at the Public Health Commission for allowing us to be part of the testimony this morning, and really looking forward to continuing to work with all of our city councilors moving forward. Thank you.
Sure. Good morning, everybody. My name is Dr. Carolyn Rubin, and I also want to thank the committee for holding this hearing today, to thank Councilor O'Malley, Councilor Flynn and JC, and Janie, and also Councilor Campbell for being here today. So I am an assistant professor at the Tufts University School of Medicine, and I also direct an academic community research partnership called ADAPT. ADAPT is a partnership between Tufts and 6 Chinatown agencies, and it's a space for us to co-collaborate, co-learn, and work on research projects together, and to create an environment such that it's not just the researchers dictating what are the health issues of concern, but it's also the community saying these are the health issues that are important to us. So as a public health researcher and teacher, I think about health as overall health and well-being. And my work in Chinatown over the last 10 years has focused on Chinatown. And oftentimes, Chinatown is seen sometimes as too small of a community to study. That's sometimes the feedback we get when we apply for grants at the National Institutes for Health. And many of you here probably know that at the state level, Asian Americans are really fighting to be able to have disaggregated data at the state level, because what often happens is that our needs get masked. And then I think even for the Chinese, that is even more particular, because, I think even Chinese in Boston could be different than the Chinese in Chinatown, which is a, very low income population. So the way that I know about public health in Chinatown is through a series of smaller, discrete studies that ADAPT has been able to support, as well as some studies some other researchers in the area have been able to do. And also what I know comes from just listening to community residents and spending time in the community. And so for public health, what do I see in Chinatown? So I see that residents struggle with some really basic needs, things that we take for granted. I've had residents tell me over and over and over again about public defecation, right on their doorsteps, right? So people are struggling with just basic needs. We know that the diabetes rate for Chinese is higher than the white population in Boston. We know that in Chinatown, 45% have high blood pressure, 83% of the Chinese residents live in public housing or on subsidies, and 53% are on WIC or food stamps. Now, we also know that air quality is an issue. We know that open space is an issue. An issue that the community has brought to us recently has been a concern around problem gambling. It's been a concern that many have known about for many years, and of course people are particularly concerned now with the opening of Encore and the type of targeting that casinos do to the Chinese community. Now, I also want to say that, and this goes against my training, but, data is important, but data is a tool, and it's also an imperfect tool. So, we did this study, we did this community needs assessment in Chinatown, and we were very interested in learning more about mental health. And the instruments we used didn't necessarily detect high levels of mental distress in the community, but that number, flies against everything that I've ever heard from residents and community leaders about the mental health needs in the community. So I always want to caution people that we have to look at data, but also listen to what residents and leaders are saying. And another issue that I have seen come forth in Chinatown is I really think that displacement has become a public health issue. So displacement is causing chronic stress. It's causing people to feel more socially isolated, have less social connectedness. There is a really, we're looking at the link between affordable housing and health outcomes. And the other issue around displacement is things are changing fast. So I have a graduate student who's done some research around food security in Boston Chinatown. And right now, she would say that at least of those she studies, there's not an issue of food security, but if, for example, at 125 Lincoln, where the developer has bought the building where Hala Moon and C-Mart stand, if C-Mart goes away, we could have a food security issue in our neighborhood. So things are changing really fast in the city in general. So I want to affirm what Monica has talked about in terms of we need to focus on the determinants, around addressing poverty, around addressing language access. And I also think that there are other strategies that we can employ. I am a transplant from California. I live in Boston now. I live in Jamaica Plain. And I think that we have this really amazing city. And I think we have, and from my work in Chinatown, we have amazing community partners. And I think what we need to do is, I think we need to invest in the community infrastructure that already exists, especially in immigrant communities, right? This is the infrastructure that's the safety net. And they're doing a lot of work, like we call it cultural brokering, that doesn't get compensated, doesn't get paid for. People in Chinatown were working on problem gambling before, people not being compensated for working on problem gambling, right? Because these are, people committed to the community. And I think we also have strategies that are being used, in the city that we can put more attention to, such as, patient navigators or community health workers, people who make the bridge between underserved and vulnerable communities with more mainstream institutions. I think I also want to put a plug in for more local studies and more community-engaged research. So like I said, Chinatown is a unique community. I'm sure that if we did studies in different neighborhoods within like Dorchester or Roxbury, and gave the community resources and the ability to articulate what they see as the community health priorities, that would help us get a bigger picture of what's going on in different neighborhoods. I think we need to innovate. I think that we need to work across sectors. I really always appreciate the Boston Public Health Commission's focus on health in all policies, so I really support that. And then the last one is, this comes, my background's in education, is the sense that, I know in Boston, so much of our attention has been put on, trying to maintain the people who come in for school and, maintain that talent. But I want to ask, what about investing in the talent of the kids who are growing up here in Boston, who can be these cultural brokers, who care about their communities? And I think there needs to be an investment and a building of a pipeline around, the public health, pipeline from the residents of Boston. Thank you.
Thank you, Doctor.
Good morning. Thank you so much for inviting me here. It's an honor and a pleasure, and I appreciate the opportunity to tackle this issue. This is my life's work, and I want to thank all the counselors and everybody in the room for giving us a chance to bring voice to many communities who often, or I'd say rarely, at tables like this. So I appreciate this opportunity. I'd like to break my comments into three different areas. First, a bit of background about what I do and why I do it, so you understand the lens I bring to this topic. Number two, I'd like to talk about what we know, both from the national and local landscape, and I'd like to humbly share three possible recommendations that would be quite concrete that I believe could help in these efforts. So my name's Joseph Betancourt. I'm founding director of the Disparities Solution Center at Mass General Hospital, now vice president of equity and inclusion. Worked very significantly both with the city and our hospital on these topics of equity, leading to our winning the nation's first American Hospital Association Equity Award in 2014. And in my work with the Disparities Solution Center in a leadership program we developed, we've worked with over 100 hospitals, 45 health plans, close to 70 community health centers in 33 states. So the lens I bring is not just a local lens, but what can we learn from other states, from other communities here that might add to the already fantastic work we do. Personally, I'm originally from Puerto Rico. I grew up in a bilingual, bicultural home. A lot of the issues that we are discussing today, I've lived, and so this work is certainly personal to me. I'll begin just a bit by talking about what we know in this space from the national and local landscape. I'd start by saying this is not a new issue. This is long-standing, this is persistent. We see improvements, but we still have a long way to go. I had the good pleasure in 1999, now 20 years ago, of being asked to serve on an Institute of Medicine committee that was asked by Congress to better tackle, better understand these issues of disparities. And 20 years later, we still understand that today, If you are a person of color, you are more likely to die of diabetes, heart disease, have higher rates of infant mortality, higher rates of cancer, higher rates of asthma, higher rates of oral health challenges, asthma, than your white counterparts, no matter where you live and no matter what your socioeconomic status is. So this isn't just about socioeconomic status variations, and that's real. We also understand, as was mentioned by my colleagues, that as we think about people of color, we shouldn't necessarily think about monolithic groups. We're talking here today about Asian Americans. There's incredible diversity within those groups. So as we think about data among all of these groups of peoples of color, we need to understand who is in our neighborhoods, who is our population, and how we tailor our approaches to meet their needs. I think that's critical, a critical part of this data. If we think about the contributors to these disparities in health outcomes, we lead with the social determinants of health. These are things that we've known about for a long time. We've called them public health challenges. They've now gotten a more attention with the term social determinants. But in essence, it shouldn't be surprising to anyone that individuals who don't have a living wage, who have food insecurity, who have housing insecurity, who can't pay their utilities, who don't have access to education, are going to do less well as it relates to their health. And so as we attempt to address all of those areas, certainly we believe we will move the needle on health disparities. And so social determinants play a very large role. The challenge is these are very big issues. And in the absence of a concerted effort that ties this to health, we move these markers, but it might take decades before we move issues around disparities in health and health outcomes. The second largest contributor is access to care. The state and the city have done incredible work around getting people insured. Certainly wonderful, but an insurance card does not meaningful access make. If individuals can't get to a healthcare provider, if they see a healthcare provider who doesn't understand them culturally or speak their language, that access is very, very limited. We see this, we have evidence of these challenges, and so creating not only insurance vehicles, but appropriate benefits and also meaningful access is going to be critical. And another area that we've tackled, the third area that contributes to these disparities, is we know today if two patients present to an emergency room around this country and they both have chest pain, and the only difference between them is the color of their skin, minority patients are significantly less likely to be referred for cardiac catheterization, angioplasty, bypass surgery, cardiology specialist care. We see this in pain management for long bone fractures, referral for renal transplantation, and end-stage renal disease. These disparities are legitimate, they're long-standing, and many in the healthcare community will say, we're trying to do our best and we try to care our best for everyone, but ultimately we still see these differences. I'll say that our city has had the great courage of asking our hospitals to monitor their quality by race, ethnicity, and so we've come a long way in tackling that area, but certainly there's more that can be done. But if I were to summarize here, addressing social determinants, improving access, and improving health care are the three vehicles that I believe are going to help get us towards addressing disparities. Now, the second point I'd make is I arrived here in Boston in 2001, and shortly thereafter, Mayor Menino and had a chance to work with Monica Valdez-Lupi back then, commissioned a major initiative on disparities, the first report on disparities, brought together leaders from private industry and the public health sector, hospital leaders, to really, I think, launch an initiative in this area. And Mayor Walsh has been equally supportive, but that initiative was very exciting. So I guess I'd like to say that we've been here before. I think we've taken our foot off the gas a bit to some degree as it relates to a concerted campaign. But our Boston Public Health Commission, I would argue, is one of the best in the nation. And their attention to health equity has been outstanding, and it now spans, well more than 15 years. So that energy is real. And I would end by saying that there is a national movement afoot on this area, but there is an opportunity for us to lead, and lead more significantly as a city. So I'll end by saying a couple of points about what I believe we can do. Number one, I had the good pleasure of serving on the Boston Public Health Commission's board, on the Board of Health for 9 years. I have seen the incredible work that they do under the leadership of multiple very, very talented directors, including now Monica Valdez-Lupi, who we're very fortunate to have. We have a dedicated team there, but as is always the case, resources are a challenge. We have a fantastic Office of Health Equity. We have, within the Boston Public Health Commission, I think, an incredible foundation to build on this work. So, of course, you're going to hear many of my comments are about resources, and certainly giving the Boston Public Health Commission the resources to expand their work on health equity and their collaborations, I think, could be a real essential target here. Number two, the social determinants of health, again, are a great target, but they can be daunting. These are issues that span education. They span all the things that we talk and care about. at the end of the day, there is a national movement encouraging hospitals to be anchors in their community. And so it's important this movement is now developing, but this anchor concept says that healthcare systems, businesses come and go, but healthcare systems sit in a community. They are large employers. They are purchasers of services. And there's a healthcare anchor network that's asking healthcare systems across the country, how might you invest your dollars in communities to address the social determinants? I think there's an exciting opportunity there to support this anchor movement. But more importantly, I've always felt like as the healthcare system is increasingly tackling the social determinants, they cannot do it in the absence of partnerships with private industry and city and local government. So how do we really expand that anchor work and take our community health needs assessments and the work we're doing, but really bring in a new set of players? And I guess that brings me to my third point. What we need is a rejuvenated major campaign with legitimate targets and accountability around health disparities. I believe that we need to provide resources to community-based organizations, but as we think about these new partnerships, I believe that our city can serve as convener, can use its leverage to bring together not just the healthcare systems and community-based organizations, but private industry, and really target these resources in strategic ways. We can move the needle on multiple social determinants, but in the absence of a concerted effort and some real targets, we'll be back here in 10 years talking about the same thing. So I thank you for your attention. I look forward to taking questions, and I'm excited about this opportunity again. Thank you.
Thank you, Dr. Betancourt. Now, I just have to ask, since Executive Director Valdez-Lupi lives in West Roxbury and Professor Rubin lives in Jamaica Plain, can I assume that you're a District 6 resident as well?
I am not, but
we'd love to have you whenever you're ready.
Very good.
It's some great neighborhoods. Thank you all for that really terrific overview, and really, really appreciate your work. I will allow the main sponsors to start with the questions, and we will start with Councilor Janey.
Thank you so much. Thank you for that very thoughtful presentation from each of you. And what I really appreciated about it was that you're grounding this conversation as a racial justice issue, that health disparities and health inequities are, in fact, a racial justice issue, and that there were discriminatory policies, or currently still are, that brought us here, and that we also have to tackle that. We can continue to provide great services at the neighborhood level through programs, through our community health centers, and that's all wonderful, but if we're not also tackling the reason why we find ourselves in this situation, then we're just going to continue to chase our tail. So I appreciate that. I also appreciate the comments, I think it was you, Doctor, who talked about that this goes beyond race, culture, language, ethnicity, and even when the income is the same for communities of color compared to their white counterparts, we still see this. And you know, my first question would be, why is that? And I'm wondering what you have seen as healthcare professionals in terms of implicit and explicit bias and how that is impacting care, access to care, referrals to specialists that you mentioned. If you could talk a little bit more about implicit and explicit bias and how that is playing out. And that's for anyone on the panel.
Can I start? Yeah. So first, I want to just second this idea that you raise, and just put a second point on this. The social determinants have become a very, in healthcare circles, a very sexy, thing that, again, we've known about for a long time. And I think what it really requires, and what we're asking people to do, is take a look at history. Councilor Flynn, you mentioned, particularly Chinatown and all these different factors. I would argue, if we look back historically, there were very deliberate policies that disempowered communities there and elsewhere, and those range from redlining and mortgage lending to where highways were put and the like. I say that because not only should we learn about our past, because people today say, well, that wasn't me, or they have this notion that there's been equity and that that things just happened kind of in some way. And you're absolutely correct. Unless we expand from health in all policies to equity in all policies, we will continue to repeat these same. We need to be careful watchdogs around how our policies might impact vulnerable populations and make sure they have voice. So I thank you for raising that. On the this bias piece, I'd say two things. When we looked at healthcare, we saw that there were probably 4 major root causes that led to disparities. Number one, navigation. It's hard to navigate the system no matter who you are, where you're from. It's certainly more difficult to navigate it if you have any vulnerabilities, and that crosses race. I mean, could be low health literacy in a white community, but certainly we see that disproportionately impacts communities of color. Communication's another one, and certainly when surveyed, minority patients feel at much greater rates that they are unable to understand their doctor, feel like their doctor understands them, or able to communicate effectively. So improving communication is important. Mistrust is a very legitimate challenge. We have many people who mistrust healthcare for a lot of different, very legitimate historical reasons and otherwise. And so building trust becomes an essential tool. But the point that you raise is implicit bias, explicit bias, and the like. And at the end of the day, I believe that we know our healthcare system is built on a model of structural racism where still many of these policies, veiled in a variety of different ways, still have disproportionate impacts on people, whether they're intentional or not. So looking at policies are going to be critical. But on the individual provider level, you know, it's really interesting because if you were to ask any doctor, do I treat people differently, they'd say absolutely not. And we surveyed people and thousands of doctors in 1999, and the not me phenomenon is very real because people come into this and they say, no, of course I want to do right by people. But what's fascinating is that we have now begun a discussion around, quite simply, how the mind works and how everybody, we as caregivers are human beings as well, and our minds take shortcuts and we make assumptions and we stereotype people, even though we don't want to do it, don't believe we do it, don't think we do it. And these stereotypes are activated the most when we're stressed, when we're under time constraints, and when we're multitasking. 3 characteristics that absolutely define healthcare today. So you have good intent, well-intentioned people who want to do the right thing, think they're doing the right thing, but are susceptible to stereotypes and they don't believe they are. And the good news is we've engaged in this discussion scientifically about how our minds work, not good or bad people, but how our minds work. 2016, 16,000 doctors were asked about bias. Now 43% agree that they have biases that impact their clinical decision-making. So a long way of saying that I think through educating caregivers to say, it doesn't mean you're good or bad, it just means how your mind works may lead to these very different decisions. We are slowly making gains in normalizing something which has very abnormal effects, which are disparities in care. So I'm confident, I feel confident that these discussions now are bubbling up. There's a lot more going on around implicit bias training, stereotyping, and the like. And it's not just healthcare. We see it in criminal justice. We see it in the legal system. We see it in many areas. But I believe there's positive energy here, Councilor Janey, and I would say that those are the factors that lead to still these disparities, no matter your race, even if your socioeconomic status is the same.
Could any of you speak to the cross-section, so the intersection between, let's say, being a woman and being black, and how that impacts our health care? And I say this because I recently saw a clip on one of the television talk shows, the morning shows that are all light and fluffy, and they were talking about breast cancer. This is breast cancer awareness. And there was a black woman on the show who was sharing her she was, I think, 40 years old, and her doctor was telling her her first mammogram should be at 50. And, my thought around this whole thing as I'm watching this play out is that may be true if you were a white woman, particularly if you were a white woman who had more opportunities around income, et cetera, that you could wait till 50. But the grave consequences for a black woman to wait until 50 could mean missing something in a mammogram. And when black women do end up with a diagnosis around breast cancer, it tends to be a more invasive or aggressive cancer. The life expectancy is shorter for black women, et cetera, et cetera. And I was frustrated watching this play out because what it didn't communicate to me is that what you may advise one particular group, that's fine, but you have to acknowledge that for this other group, there are different outcomes. And it didn't kind of do that. And so I wonder if you could speak to the intersection when it comes to gender and race and class and how that plays out in the healthcare field. And that could be for anyone. And what are we doing to combat that? Like, what are we doing to acknowledge that Black women shouldn't wait till 50 to get their first mammogram?
So I can start. There was a group that started actually under Mayor Menino, but Mayor Walsh just recently had them in earlier this week, our Pink and Black group. And this was really to your point in terms of Black women in particular who have some of the highest screening rates locally in the city and statewide in terms of getting screened and getting their mammograms, and yet dying. Their mortality rates from breast cancer, colorectal cancer are much higher than whites, despite the fact that they're screened. Some of the things that Dr. Betancourt mentioned in terms of care, when you are diagnosed and it's at a later stage, you have to have all of these wraparound supports. And I think this is why social determinants has gotten to be a really sexy label now, because hospitals and insurers and the way that payment reform is changing the landscape of how our providers are being paid is that these community health workers, coordinated care, the patient navigators, that's essential to have when you have a diagnosis, and to have someone who has the same lived experience, who reflects, who is reflective of the population that you're serving. We just recently met 2 weeks ago with American Cancer Society. The topic was on colorectal guidelines, colorectal screening guidelines, and they have a campaign where they're trying to get 80% of Blacks screened by the age of 45 because they have higher risk factors. And so a lot of it is we are having a lot of positive trends in terms of screening, but there's so many other things that we have to be vigilant about in terms of making sure that once you do get that screening and there's something that comes out, whether it's a mammogram, a pap smear. For Asian Americans, they're experiencing cervical cancer at higher rates than Latinos and Blacks. So when you get that positive test result, you need to be able to get care given in a language that you can understand and with providers that look like you. And I know that Dr. Betancourt, through the Disparities Solution Center, did a lot of work in this space, both locally and nationally. And I don't know, Carolyn, if you have information from the research that you've done at Tufts specific to Asians.
Yeah, I want to, let me ask this too. So also in the presentation, someone mentioned displacement and gentrification, and I think that's huge in terms of a public health risk. We know from listening to the news just every morning, you hear about electronic cigarettes and the health risks there. We think you mentioned gambling and casinos, the opioid crisis. What more can we do, particularly like with our students, our children, around making sure that they understand the risks? What are there programs in schools, at the community health centers around like opioid use, electronic cigarettes, and how that's impacting? I think one of the panelists mentioned mint and menthol campaign and how they're targeting, historically have targeted communities of color, particularly Black people around menthol cigarettes. But we see the same thing with the electronic cigarettes for our young people, flavored cigarettes, et cetera, et cetera. How do we know what will happen if we do nothing, right? That we'll see a new generation that will be subjected to cancers, et cetera, respiratory illnesses. What can we do that really looks at this issue, and do we need more programs in our schools if we're trying to combat this in terms of young people? Same thing with our STDs and making sure we're doing more screenings there. Are we in the schools in a substantial, significant way? Is there more that we can do to reach young people and their families beyond our community health centers?
So I think there's always, we can always be doing more. I'm happy to share that we are working closely with Superintendent Casilius and her team post, I think, release of the governor's executive order around vaping. But we've been doing work with BPS for many years through our school-based health centers and through our peer leaders in terms of raising awareness and promoting prevention messages using the high school students themselves. So, and with the mint and the menthol, we relied and worked with our community partners when we held a community forum this summer. We held it in July at Codman Square at the Great Hall. And that was Cynthia Lesh, who was one of our original, I don't know, Joe, if you remember her, she was one of our original bold teens. And now she's, an adult, a mom, and she had this next generation of bold teens with her talking about the impact of mint and menthols and e-cigarettes and vaping in communities of color. So I know that Chinatown also has teens who are working around raising awareness and prevention around e-cigarettes. And so I think the youth and the young adults in the cities are activated, and we can always do better in terms of mobilizing them. They're the best champions in terms of working with their peers around whether it's opioid use, marijuana, menthols. They really are the partners who we bring to the table. I was just with a group last night of our youth advisory board at our Boston Area Health Education Center, and we have a curriculum on, it's called a porn literacy curriculum, which we do in partnership with Emily Rothman at BU School of Public Health, and they were talking about healthy relationships. And I learned things about, I didn't know there were 7 types of intimacy. And so these youth, these high school students are the ones who are carrying out our public health messages in the schools. And I think there's a lot of opportunity to strengthen the work and continue to grow the resources that we're investing through our programs at the Public Health Commission, through BCYF and BPS.
I wanted to also respond to the question about implicit bias. And I particularly, because I wanted to respond to the question around implicit bias and actually give an example in the Chinatown community. I think the way that, because as we've discussed, all communities of color are different, there's heterogeneity, even within Asian Americans. But what I see happening a lot in Chinatown is that Chinese get blamed and say it's your culture. So why do Chinese gamble? Oh, it's in your culture. How come, they're not accessing services? Well, because the parents are passive and they're not seeking services. And I think that it's victim blaming, and it puts the onus, on the person versus putting the onus on the system. I know that my colleague Don Salma from the Asian Task Force Against Domestic Violence, will be testifying and can testify to this as well. I had a student who did a small research project with ATAS last year, looking at the service system for domestic violence survivors, finding that it's the system, a fragmented, broken system, that is the problem, where too often we say, well, it's the culture of the person, and that's why they're not getting services.
I appreciate that. Thank you all. I want to be mindful of time. I have more questions, but I can wait or maybe connect with you after the hearing. Very thoughtful. Thank you so much for your work, and that's it for me for now.
Okay, sounds good. Thank you, Councilor Janey. Councilor Flynn?
Thank you, Mr. Chairman, and thank you to Councilor Janey for her excellent questions. It was very informative, the discussion going back and forth, and educational. I just wanted to focus on a couple comments that were made. I am working with Council President Campbell on an upcoming hearing on domestic violence and sexual assaults, and we've been meeting a lot of providers across the city and the state. I've been focused on what impact language access has on this, what is the impact of being an immigrant on this particular issue. But my question really focuses on language access in general in public health. I think you mentioned, Doctor, that there are so many different Asian American communities across Boston, across Massachusetts. So what happens in Chinatown with the Chinese community is very different than what happens in Dorchester with the Vietnamese community. I also do a lot of work with the Vietnamese community as well, although they're not in my district. But do we have? I don't think we have enough data. I don't think we concentrate enough on really diving into the Chinatown community itself, looking at the unique problems, social problems, health problems of the Chinese community in Chinatown. I think it's oftentimes lumped in with all Asian communities across Boston, including Brighton that has a high, and Allston that has a high Asian community. But if we're doing that, are we not getting an accurate picture at times because the data is not accurate? I had the opportunity to testify in favor of Representative Taki Chan's proposed legislation last week in favor of it. I want to see us break down, I want to see government break down ethnic groups so that we can really get a fair and accurate portrayal of exactly what has happened. But I think because we're not doing that at times, we don't have the accurate story.
I do agree with that. I mean, I do agree that we don't have accurate data on Chinatown. I think that, about 5 years ago, a lot of our community partners came to us with that very issue, that they weren't able to discern the data on Chinatown from the health of Boston, back then. And so, Tufts was able to secure $50,000 to do a study, and we did it as a population-based random sample so that we could actually compare it to Health of Boston data, and we used many of the questions from the behavioral risk factors surveillance survey. And we've been working with the Boston Public Health Commission. Monica's team has been great in helping us, work on that data and to be able to compare it to the greater or to the city of Boston. And I believe you've seen some of that data. Yeah. But as I mentioned, in my remarks, we need more data, but also data isn't perfect. It's also that very survey from which we couldn't detect depression and mental health concerns in the community. But like I said, everyone that I ever talked to in Chinatown will say that one of the top concerns in Chinatown is mental health. So I'm not sure if it's a measurement issue or if I'm not sure, but there are, we are still working on trying to find out ways to get reliable data, from the community.
Yeah. I know I spoke on and off for the last 2 years with public health on that particular issue. It was always my goal to continue working with the city of Boston, with public health, but really to dig deep into Chinatown and do a specific in-depth study about the public health concerns in that community. And that's something I would really like to see happen. And I know I spoke to many people at the mayor's office and with Director Lupi as well about that issue. Director, do we have any more updates on that particular issue as it relates to what we were speaking about?
Sure. So I know Carolyn can probably share some of the details, but I know that we were able to, because they used, and this might be a little in the weeds, but they used, the good thing is that the survey that they did actually used questions that are the same questions that we use in the behavioral risk factor, the BRFSS survey. And so we were able to do some additional analysis and weighting that allowed them to tease out some of the data that we didn't do in Health of Boston. Mm-hmm. So I understand that in that initial deeper dive that they were able to see that Chinese adults in Chinatown experience lower rates of asthma, and then they also experienced higher rates of diabetes and hypertension when compared to Boston residents as a whole. I think we have to continue to work on how to collect the data, and BRFSS, as you said, it's not a perfect tool, and some of the more qualitative data I think that Carolyn talked about might be a different way of gathering information. We saw this when we did the community health needs assessment with the hospitals. So that was a online survey, very long, about 45, 50 questions, I think. And what we were able to do, I think in partnership with Tufts and Sherry's team, was do smaller focus groups. And I think when you are working with different populations, particularly populations that might not be the first to do that online survey or to take a telephone survey because of language barriers. We have to think creatively about how we collect the information.
I wanted to also add, so this survey that we did, it wasn't online, it wasn't by phone. We actually hired bilingual, bicultural survey, community field researchers who went out into the community, knocking on doors to recruit people and then administered the survey verbally. And I think because of that, we were able to get a high response rate because, and I think this predates you, Monica, because I think years ago when we asked the Boston Public Health Commission about, doing the BRFSS in Chinese over the phone, they actually said that even when they've done it over the phone, they don't get a good sample size. So that's why we went door to door. And so, but it's important to know these are resource intensive. These are more resource intensive studies, but I think that they are just as important because then it allows you to really drill down and really understand what's going on in the community.
I would be happy to talk more with you, Councillor Finn, and other councillors if you'd like to learn more about the administration of that survey. We're in the process now of working, as you know, on our FY21 budget requests. Even the straightforward BRFSS survey, because we do a lot of oversampling, is very expensive.
Yeah.
And we would like to be able to do more work that gets to the type of granularity that you've been talking about over the last 2 years in the Asian community and Chinatown in particular. So I think there are opportunities, and happy to talk with you and Carolyn and Sherry afterwards if you'd like.
Yeah, that would be excellent. Thank you. I know all three panelists mentioned the breast cancer issue in the Chinese community as well. Asian women have a longer wait time after an abnormal screening and lower screening rates on breast cancer as well. I often think about in my community in Chinatown, where we're practically surrounded by hospitals, great hospitals. We're surrounded by great health centers, great colleges and universities. How can we do more outreach to Chinese women on this particular issue? And what strategy would be effective to get more women aware of the importance of examinations and education on this particular issue?
So, I know my colleague Chen-Chi Huang is also in the audience. I'm sure she can speak to this as well. But I think that, for an immigrant community where there may be either a lack of awareness but probably also maybe more distrust or fear of the medical system, I think that, these cultural brokers that I was talking about, that sometimes we call them patient navigators, sometimes we call them community health workers, these are people from the community who are seen as trusted, allies, interpreters, and bridges, between, more mainstream institutions, these big hospitals and local communities. And I think that these are assets that we have in our city, and I think that, that we need to, allocate resources for them as well, and also for them to happen in community settings, and I don't mean just community-based organizations, right? I mean, depending on what community setting makes sense, like for example, is it the faith-based organizations, but to meet people where they are at, and to do it with people that are sensitive, to their needs and to their cultural concerns.
There's countless examples of how community health workers, healthcare coaches, navigators have significantly narrowed disparities in breast cancer, in colorectal cancer, in cervical cancer. And the challenge is that our current payment model, which is fee-for-service, does not support the sustainability of those programs. Those programs are often grant programs, community-based programs that receive some funding. They show great results, but at the end of the day, within the current healthcare financing system, they're not supported. And so, there's a graveyard full of incredible interventions like that leverage the strength of the community and that narrow disparities in these areas. Now, our push, as Monica was mentioning, towards value-based contracting, I think gives us an opportunity to invest there. But I've always felt like partnerships, city, private, public, that would support in communities, community health workers, navigators, coaches, to do this incredible, proven, efficient work as we continue to build out our value-based contracting is where the money's at. I don't necessarily believe, especially in Boston, that we need more doctors and more nurses. I mean, we have plenty of those. This is where the leverage is, and quite frankly, this is an opportunity for empowerment for those individuals in the community and getting them on a career ladder as well. So I think you do multiple things at once.
Thank you. I referenced it in my opening statement, but I also represent a large Puerto Rican community in the South End. I also represent a large African-American community in the South End and in South Boston particularly, in many of the public housing developments. So I'm proud to represent both of those communities as well. What are some of the unique public health concerns in the communities of color as it relates to residents living in public housing developments?
So I can start. We've been doing a lot of work that I think you might be aware of. I'll talk later, actually, in the second panel this afternoon.
Okay.
About partnerships that we have around maternal health with the Boston Housing Authority, and this really happened, counselors, with the leadership of Director McGonigal, and I know I saw many of you a couple, I think it was just last week, at his funeral mass, and he had that lived experience of growing up in South Boston there, and so he was a big champion of ours in public health. So everything from the work that the environmental health team does at the Boston Public Health Commission around healthy homes and integrated pest management to address higher asthma rates in BHA properties, to looking at food insecurity and healthy eating and increasing physical activity. Those are the things that we've been working on over the years with partners in BHA. We also had done, now I think it's 3 years ago, we do summer community dialogues, and we worked with BHA and D&D in convening a series of conversations on the impact of housing on health, and so issues of displacement, issues around lack of transportation. Those are the sorts of things that we've worked on with our other city partners and other community partners. But all of the issues, I think, the health issues that we've talked about, you see are exacerbated among people who are already living, they're living in BHA properties, but they often experience higher rates. And we can give you that data because we actually did, I think that is in the most recent Health of Boston, where we looked at housing status among individuals who responded, who were in public housing, respondents who had Section 8 housing, and compared it with renters and also people who owned their homes. And not surprising to see higher reported experiences around the chronic diseases and also experiencing mental health and behavioral health challenges. That is actually broken out in the Health of Boston report, and we can provide that offline.
Thank you very much, and in the interest of time, I'm not going to ask any more questions, although I could ask more questions for at least another hour. You guys have been very informative and providing great information, but I know the council president wants to, is next, so I'm not going to ask him more questions. Thank you.
Thank you.
Thank you, Councilor Flynn. Madam President?
Thank you, Councilor O'Malley, and thank you guys for the thoughtful and very frank, points that you've made, and thank you for the work you do in your respective spaces. I'm sure it is challenging and difficult every day. I think I'm telling myself not to be depressed over here, frankly. And what I mean by that is, I think you said this, Dr. Betancourt, that these are long-standing, persistent issues. They're big issues, and when you look at the social determinants in particular, they're big issues. And so it will take us some time to address them. But then on the other hand, our residents don't have time, right? So I just really appreciate the work you're doing and for sort of naming some of that. Where do I begin? So I have a lot of questions, but I'll try to start with just a few and for the sake of time. One of the things I thought was really powerful was this conversation around data and really naming the fact that data is not perfect, the importance of both quantitative and qualitative data, community assessments, conversations with real people to see if the data that we have actually is accurate or complete. And it's one thing that we talk about, I think, with respect to every issue. Education is a big one for me, and you think about disparities in education, particularly within the Asian community, and if you do not disaggregate that data, you miss the picture. Particularly when you think about my district, I have a large Vietnamese population, and by some metrics, they are doing worse than Black and Latino students. You would never know that, experiencing very significant mental health issues in the education space that often don't get talked about. So I'm just curious, it sounds like we still have work to do, investments need to be made to really come at this from different angles, to really get data from the community in different innovative ways. But I'm curious who is doing it maybe really well. It sounds like there has been some folks in the community already who have already done this in Chinatown. But who's, from the medical institutions that are right here in our backyard that do have significant resources, who's making this a priority, who's doing it well? I'm just curious to know who some of those players are in terms of investing resources, human capital, expertise in gathering the data that is so critical to paint the picture of the problem before we jump into solutions. Or maybe no one is. We have work to do.
With an approach that we've taken going back to 2004. So this is the bottom line is that you can't manage what you don't measure. Pushing our capacities to better stratify by not just race and ethnicity, but this state and the city had the courage to require our hospitals to collect race, ethnicity, language proficiency, and highest level of education. Mm-hmm. And I believe that this move towards big data really can be applied to healthcare. And so that's one. But number two, looking under the hood is really, really critical. We measure patient satisfaction because of requirements, for many, many years. And what's lost in that measurement is that the people who reply to those patient experience surveys and patient satisfaction surveys, rarely represents the catchment area and the entire community who receives care in our institution, for example. And so in 2004, we set up a series of resources to do exactly that. How can we make sure we are going, using different techniques to hear from our communities of color who we know get care from us, but who we don't see in our patient experience survey results, and asking them questions about their experience, but also about racism, about trust, about disparities-related issues. We did that in 2004, and as you might imagine, we learned a lot of interesting things that our basic survey tools didn't tell us. But it took, as was mentioned, dedicated resources, specific efforts, but these shouldn't be one-offs, they shouldn't be ad hocs, they shouldn't depend on some institution's goodwill. We now have done it 2004, 2012, 2017. We're going to do it probably every 2 years or so, where we take specific efforts to make sure we're hearing from everybody. And I think that approach needs to take root not only in our healthcare institutions, but also in our communities. And I would second this idea that, too much data can, sometimes you don't need data to prove the obvious, things that you see every day. But data also could be helpful as you develop targets for improvement and interventions.
And that sort of connects to the other point around sort of the investing in community infrastructure. The assets are the people on the ground willing to volunteer their time to be a part of the solution, the organizations that are community-based. One thing I love about my district, and it's largely Mattapan and Mattapan and Dorchester that I represent, from Lower Mills all the way through Grove Hall. I have a little bit of Jamaica Plain and Rosendale. I say it's where all the inequities live, every category you can imagine, predominantly a district of color, pockets of poverty, public housing. Franklin Field has been touched in 30 years. And so the thing that is often lost is the number of folks on the ground doing the work, whether it's through a civic association, some other tenant organization, a community-based organization, a nonprofit, and we are being more intentional from my office of investing as much as we can into these groups. You think about data collection, the people who are on the ground. If you invest in them, what might you learn in terms of the data piece? But how might you utilize the fact that they have built trust with populations that often distrust systems and a whole bunch of systems? And so I'd love to hear a little bit more on what the city could be doing or thinking about doing in terms of, and through the leadership of, Monica, and the work you're doing at your agency, to better expand the wherewithal, the capacity for all these folks get burnt out, to do that work, to be bridges, particularly around this healthcare issue.
As you're talking through that, Counselor, the example, there are two things that come to mind. So the one example that I know you're very familiar with and have been a good advocate for us is around our neighborhood trauma team networks. And that really was, Mayor Walsh who asked us to think about how do you redesign a system to respond to the impact of violence in our neighborhoods and our communities that wasn't so focused on the clinical care side, which is important, but then how do you work with community-based responders? And that's the system that we have now, where a community health center has to partner with a community-based organization that then provides resources to community members who are volunteering or who are civically engaged and going out and doing that first response at the scene. And how do you compensate and provide resources to build agency and capacity at the neighborhood level? So as you're talking, that's one example I can think of where could there be opportunities to look at that, and how could you expand or build from that? The other example that I would share with you is in working with our colleagues here at City Hall and Chief Barros, and the work that he oversees in economic development. We just rolled out this summer a policy at the Public Health Commission that's focused on equitable procurement and how do we build, how do we increase the number of grants. We have over 1,000 contracts, millions of dollars in city and state and federal funding that we receive that we push out through requests for proposals into communities. But even in terms of the vendors that we work with, we can do better. And so we developed a new policy that I know the staff have been here at City Hall sharing that policy and providing some technical assistance to other departments who want to look at the data that they have on their contracts, and how do you better invest in what we're describing as CUBES, Certified Underrepresented Business Enterprises. I think it's a long word, but the acronym is CUBES. And so that's another example when I hear you talking about agency and building capacity at the neighborhood level, that we're thinking a bit differently at the commission about the work that we do. And I know the hospitals are doing this in terms of their needs assessment and the health improvement plans, and thinking really outside healthcare. How are they hiring people from the communities? How are they contracting with different vendors in the communities to provide services and goods?
And I'll just add before we, even in the public safety context, one thing that you said is so critical is we do have millions coming through the city of Boston, whether through our own budget or external resources, private, nonprofit, or federal or state, and the importance of measuring through some metrics we define with a provider or a vendor that we give our money to, at the outset, what we want our outcomes to be, and really making sure that we're giving resources to those folks on the ground who are going to have the impact we anticipate. I think sometimes we do that well, and then in some areas there's some work to be done, but I appreciate the examples, Monica.
I also agree that with the move for, I also think there is an opportunity for working more with the hospitals. Someone was mentioning that, people are beginning to think about hospitals as anchor institutions in neighborhoods. And one thing I know that's happening in hospital now is that hospitals are being asked to screen for social determinants of health. But my question is, but what are they doing with that data? And it's good to know, if people are food insecure, but then how do we address that? And I know there are hospitals around the city that are, doing different things, but I think that there needs to be a more intentionality. And then this is where we come, I think the pathway of partnering with different, community level partners can help, fill those gaps, and in ways where they do get compensated. I know that at Tufts there was there's been an interesting example of using patient navigators in the Tufts Cancer Center, and it started with a grant, from the Susan Komen Foundation, and I think because the program was very successful and was able to show positive outcomes, with a lot of work, Tufts actually has put those patient navigators in their operating budget right now. So similar to what Dr. Betancourt was saying, I think we need to find a way to institutionalize these resources that we know do work.
That's a great example. And another thing that came up was just, first of all, thank you for mentioning Cynthia Lesh, who is a District 4 resident. She lives in my district, so I was very happy to hear her name mentioned. But another thing that came up was just the resources that your agency needs to be able to do this work in terms of the Health Commission. And obviously, every year we're in budget season, and my new question has been, at least in the last budget cycle, to various departments is, what was the proposed budget you sent to the administration, and then what did you actually get? But I would love to hear a little bit more from you, Monica, or even Dr. Betancourt, who brought this up, around what those resources look like. Is it, increase in monetary dollars? Is it more human capital? Is it something else? But what does a health commission that is adequately and appropriately resourced need to be, I guess, in order to do this very work that is so critical? I wanted to sort of pull that apart a little bit.
So we're just beginning our FY21 budget planning process. Something that we implemented when I came back to the commission was integrating, and I had learned this from other colleagues, frankly, who are from Minnesota and Washington State, who at the state health departments were integrating an equity assessment as they were looking at bills that were being filed, budget proposals that they were submitting, so that there could be some objective criteria for the programs in addressing health equity. Again, how do you integrate equity into the day-to-day work? Happy to talk more with you about that process, but we're just beginning that. And so there isn't a simple answer to what exactly would we need. Is it more people or more or resources? Because I think it's a combination of the two. I don't think there's a gold standard or a benchmark in terms of what a health department should have in terms of whether it's staffing models or resources. We actually do have diverse resources that we've been able to braid at the Public Health Commission, and this is just over the years in terms of the grants that we submit. So every grant that we have submitted since I've been back, and I'm sure under Barbara Ferrer and John Auerbach, had racial justice and equity as a central focus in our grant applications. If we, which I'm happy to provide you with, the recent the grants that we've received from SAMHSA, actually from Department of Justice, the RISE grant that I mentioned to work on the substance use disorders, all of those grants that have come back to us have a racial justice health equity lens that's been built in. So we are proactively building that in to our grant applications and our city and state budget requests. And I'm happy to talk more with you about how we do that.
Just to be mindful of time and public testimony, thank you for the work you're doing. I'll have more questions, but I can follow up with folks separately. But I did want to echo just what Councilor Janey was saying when she was asking questions of the panel in the importance of racial equity and equity lens. I really applaud you, Monica, your team, and even the previous teams at the Health Commission and leadership for using that lens, particularly in the government space, because most of the inequities that we are talking about were created by us. And we need to name that for folks in a very honest way. And then in getting at the solutions to solve for these problems, we have to bring that lens and that historical context, particularly in the city of Boston, to everything we do so that we're not putting forth policies that perpetuate inequities or that are having unintended consequences. And so 10 years or 20 years from down the line, we're talking about the same thing. So I appreciate each of you stressing the point of using equity and the work that you're doing in your individual spaces. So thank you, and thank you again to the sponsors for this. Thank you.
Thank you, Madam President. Thank you for joining us, District 1 City Councilor Lydia Edwards. Councilor Edwards.
Much. I want to thank a lot of the folks. First, I want to acknowledge the incredible work, and if I'm between public testimony and if my comments are, then I will just make some broad comments, some suggestions, so I can hear from the experts in the audience, many of whom I know personally, and I want to thank you already for the work that you've done on the ground. So I'll just say this. I represent East Boston, Charlestown, and the North End, and if you want to talk about income inequality and also equity issues, my district probably has some of the most extreme, where we have some of the $1 million homes across the street from the largest housing development in New England. And so all of the topics that you're talking about directly impact parts of my district. So I just wanted to make sure that when we're talking about health disparities, that part of our conversation and comments will address environmental justice corridors. Particularly my community of East Boston is right by the airport. And so one of the issues that we are seeing is the measuring of ultrafine particulates in the air that impact East Boston, which is 60% Latino. Wanted to make sure that when you're discussing or looking at the health impacts, that you're looking at those kinds of major neighbors or industries next to a neighborhood. And also looking at ways in which we've responded, healthcare facilities such as BMC now prescribing housing and their new housing grant. I think that's an innovative way of looking at how healthcare facilities, healthcare hospitals can step in and prescribe social, programs or social, benefits as part of the healthcare dialogue, and I think that's an innovative way of looking at it. So I would love to further the conversation about prescribing HEPA filters when dealing with the ultrafine particulates, and that's based off of what we did with Massport, where they literally gave us windows for all of our homes because of noise pollution, which I don't know that we discussed today, and the impact on the hearts and on the I think it was, I learned it impacts your heart, it impacts your anxiety, and there was a third one, and I apologize. I just met with some folks about noise pollution. So looking at infrastructure prescriptions that healthcare facilities could start to push out as part of the narrative of benefits, I'd love to have that conversation. Also, I wanted to make sure that we kept in on the public housing and the disparity conversation. I do appreciate, and I have seen with East Boston Health Center especially, coming out door to door, doing that kind of outreach. But because we're in such a unique and I think moral position, because it's our housing, we should be leading actually in destroying disparities in the housing that we're providing for individuals. So I'd love to see a prescription-based understanding of how public housing can immediately, right now in its infrastructure, address the disparities, racial disparities of the folks who we have decided as a moral obligation to provide housing for that. So I know that that's a lot, but again, if it's just between me and hearing from actual experts, I'm going to close out my comments. I look forward to talking with you individually, and I'm really excited to hear from the folks in the audience.
Thank you, Councilor Edwards. So just briefly before we get to public testimony, I wanted to, three very brief follow-ups. One, appreciate all the thoughtful questionings from my colleagues and the terrific answers for you. Councilor Janey brought up the intersection of class and race and used the example of breast cancer, which was a terrific one. I'd also add to that, as we sort of look at this and going forward, the incredibly higher rates of breast cancer in lesbians as opposed to their straight counterparts. So that's something we should be mindful of. Secondly, as it relates to the vaping ban, which I wholeheartedly support, and I know we talked about menthol mint. I'd also add wintergreen for that, three of the non-flavored categories that I think the vaping industry and the e-cigarette industry has gotten around to, again, go after young people and in communities of color. There's been sort of this anecdotal evidence, and it may be too early to actually know, but I'd ask any of you, that the vaping ban has actually caused folks to go back to combustible cigarettes. Is there any data to back that up, or is that a scare tactic that folks from the e-cigarette companies are using, or is it too early to tell?
I think it's too early. I think that was a concern.
Yeah.
That even our public health colleagues had raised in terms of harm reduction, that it would push people to go back to cigarettes, but I'm not aware of hard data at this point in time. I forgot I should put a plug in for our public hearing, which will be on November 7th, so I hope that, and we're doing a lot of outreach to promote that.
Terrific. Great. Thank you. And then finally, can you just talk briefly, give me the Reader's Digest version on our policy on vaccinations in school and sort of outreach for parents, particularly in BPS? Or is this a Dr. Casilius question?
This is we're actively engaged in conversations with BPS and Dr. Casilius. I just came from an earlier meeting with our medical director, Dr. Jennifer Lowe, and so there are some things that are being planned, and happy to talk more with you.
Great.
About
I mean, that in and of itself could be a terrific separate hearing from this, so appreciate that. Could work. Thank you all. I invite you to stay around. That concludes our questions, unless there are any follow-up questions from my colleagues.
I
Please.
actually just had one, since you brought up.
Sure. Thank you very much.
Wait for the microphone here. That's okay. Just a quick follow-up, since you brought up the e-cigarettes and whether or not people are going back to traditional cigarettes. I think another concern that people had regarding the ban was that it would force people to go back into the illegal market. So people who may have been buying their e-cigarettes from stores that have, regulations in place, et cetera, are now kind of going underground. Is there any evidence of that? Do you know?
Again, I think that is something that we have read about and heard about anecdotally, and we're all sort of in a holding pattern, watching and waiting to see what happens with the state's ban. I think they have until Monday, from what I understand, to do some. There are various court proceedings going on.
Okay.
But that is actually anecdotal, the concern that was raised too.
Okay, and I see.
At Mass General, we have two people who have been real leaders on this, Drs. Winnikoff and Drs. Rigotti. They probably would have data on this. They're tracking this. Dr. Winnikoff's been in the news a lot around what's happening, but just as a resource, I'm sure there's many, but these people probably could provide some real cutting-edge perspectives on this.
Thank you so much.
Thank you, Councilor Janey. Councilor Flynn, last word.
Thank you, Councilor O'Malley, and again, thank you to the panelists for your excellent testimony. I just wanted to follow up on one brief comment, Monica. You mentioned, and I certainly agree with you, but pest management is an issue throughout public housing developments. It's really an issue throughout the city as well. I also think it's a public health related concern, and that's something I've been doing some research on, and I do hope to have a hearing probably sometime next year on what impact does pest management have on communities of color, especially in my neighborhood of Chinatown and some of the public housing developments. So if we have an opportunity to continue to work together going forward on pest management, I think that would be very important.
So definitely look forward to that, and would bring along or suggest bringing along colleagues from ISD. We work in partnership with them as well.
Excellent. Thank you.
Thank you, Councilor. Thank you all to the panel. Again, you're welcome to stay in those seats or stick around if you want to listen to some public testimony. We have a number of individuals who are looking to testify. We do have this committee will be at the conclusion of this hearing, taking a break, and then reconvening at 1 o'clock on the Black Maternal Health hearing order authored by Councilor Janey and myself. So thank you all for your great work and partnership. And I've got, I think, 5 or 6 folks have indicated they'd like to testify. If you have circled no, but would like to now testify, we will take you at the end. Or if you have not signed in and decide you'd like to testify, we will, of course, take you after these folks. So the first person I have indicating they would like to testify is Qian-Chi Huang, followed by Don Salma. And you could just grab either of these if you had to line up at the respective microphones on the left and right, whichever you prefer. And again, we'd like to keep it to 2 to 3 minutes, but I'm not as hard and fast on time limits as some of my colleagues that wield the gavel. Yep, you can take the standing one's probably easier, if you don't mind. Sorry. There you go. Thank you.
You never know. So, my name is Qian-Chi Huang. I'm an immigrant from Taiwan. I'm also a breast cancer survivor. And before I started the nonprofit organization Asian Women for Health, I was the Asian Community Program Manager working for the Massachusetts Council on Compulsive Gambling. So I have both personal and professional experience working in the Asian community. And today, I would like to focus on the number one health disparity in the Asian community, which is cancer. So as you heard from the previous panel, I'm not going to repeat some of the data because you have it there. But then one thing I wanted to bring to your attention is that the Boston Public Health Commission has the most recent cancer data. And in it, it says that there's an 89% of increase of breast cancer of Asian women in Massachusetts. And I was one of those number. The data was from 1999 to 2013. And also, I have noticed that there's an increasing number of Asian women who are being diagnosed at a younger age. So, and Dana-Farber also recently have their own cancer report, and I'm on their advisory committee, so I got to see the report. And it says that all cancers are up for Asian women, and Asian men has a higher rate for lung cancer and liver cancer. And I also wanted to point it out that in Massachusetts, we have efforts to looking at Hep C, but there's no concerted efforts to focusing on Hep B. And Hep B is disproportionately impacting certain populations, like the Asian Americans and also Africans who are born outside of United States. And on the other hand, Asian Americans had the lowest utilization rate of screening, mammogram, pap smear test, and colonoscopy. So I would like to offer and address some of these gaps by offering some suggestions. So number one, I think that we should definitely think about providing trainings for providers. As Dr. Bendacourt said that providers tend to have unconscious bias. And I have an example where a Chinese breast cancer patient who were misdiagnosed and delayed the diagnosis twice by the provider because they don't think that Asian women will have breast cancer, or because they think that, because she can't really communicate her concern to the provider. So they just thought that she needs to have physical therapy for the back pain, but they delayed the diagnosis, and it turned out that the cancer was spread to her to her bone. So this kind of things happen a lot, and it's not being captured. And so I'm very lucky. I'm the one who lived here, to tell the story. But I just wanted to raise to alert you about things that happen. So number one, I think that it's crucial for us to do training for providers. And like the previous panelist said that, providers tend to treat patients differently based on their, skin color. And so we need to make sure that, the providers not only have culturally, have materials translated in the appropriate languages, but also they are trained to treat the patients as a whole person, not just to treat the disease. And number two, I think that we need to look at and also to give funding to place-based program. I know that there's a talk about anchor-based program, but I think that we have to realize that most of the people live and work and study in the community. We don't do this kind of living in the hospital. So to have this kind of outreach education work to be really effective, we need to do this. We need to meet people where they are. And we have been very successful in partnering with residents association to do screening and education outreach program, like at the Castle Square Tenants Association or Roxbury Tenants at Harvard. We also, in the past, when I was working for the Mass Council, we have done outreach education in the nighttime, like after the restaurant worker get off work at the church. And so we need to be more creative and more innovative and think about how we can reach out to those underserved and underrepresented population.
Thank you. I just want to be mindful of the time.
Sure, okay.
Thank you. So if you could wrap it up.
So
with a concluding-
two other things
Briefly, please.
Yeah, so I will advocate for the workforce development and to train community members to be community health worker, interpreters, and peer specialists, especially people with lived experience, that we can share our stories and we know the community, we can help them navigate better the healthcare system. And the last point I wanted to make is that I think that, yes, we do need more research, but we also need to allocate resources for the community to capture and document the data, and to be mindful that the results should be, that whatever efforts that is, that it should be data informed, not just data driven. So for example, the BRFSS, the regular health survey, it's done in only Spanish, English, and Portuguese. And it doesn't include the Asian languages, and also it's self-reporting. So when you have that kind of research method, the data is already skewed or not include a lot of the population who don't use landline. So I just want the counselors to be aware that when we're talking about data, when we use data as a measurement, it should be data informed and not data driven. That's it.
Thank you, Chen-Chi.
Yeah.
Thank you, appreciate it. Don Salma, and then Rachel Miller will be after Don. Thank you.
Hi. Thank you, Councilor O'Malley, Flynn, and Zaney, for raising the issue of health disparities in people of color. My name is Dawn Salma. I am the co-executive director and clinical director of the Asian Task Force Against Domestic Violence, otherwise known always as ATASK. We are a statewide nonprofit organization that's been serving the Asian victims of violence in Massachusetts for over 26 years. As a direct service community-based organization, my goal is to bring the perspective of a highly marginalized population. Annually, we serve over 600 households across the state. 98% are Asian and have immigrated from over 30 different countries and territories in Asia. They speak over 35 different Asian languages and dialects. The majority of the 600 households are first generation, new, immigrant and refugee, low income, without social and familial resources, and are in the brink of crisis. Do you want me to slow down?
No, I love it.
And believe
Don.
me, I was winding that, I was slowing that down.
Keep it up, Don. I love it.
Anyway, linguistic and circumstantial barriers are compounded by cultural barriers. Abuse in Asian communities is considered a private family issue, and customarily does not escape those confines in any circumstance. Additionally, many deeply ingrained cultural values such as prioritizing family over self and not bringing shame and disruption to the family balance discourage Asian victims of violence from disclosing abuse or seeking help. Racial comparisons show that Asians experience domestic violence twice as much as white, Latinx, and Black and African American survivors. Immigrants are 2 times as likely to be killed due to IPV than non-immigrants. And 19% of Asian women report being pressured to have non-consensual sex with their partners. And severe underreporting suggests that these statistics are a lot higher. These combined circumstances place Asian victims of violence at high risk for being disserved, underserved, or not served at all due to systemic barriers. And in general, most consumers who speak English manage their own life needs. They communicate with their health workers, attorneys if they have legal issues, with their children's teachers, and police for emergencies, etc. So the consumer is their own managed care provider for their own personal needs and navigate multiple systems. This is a natural function that becomes very challenging for a consumer that does not speak, read, or write English, particularly when they don't know that resources exist and providers don't speak their language. Currently, our language access solutions are inadequate. Number 1, domestic violence victims interact with multiple government and community-based systems whom have limited cultural and linguistic capacity to competently and comprehensively address the needs of Asian victims of violence. The problem is that every one of these touch points, Asian victims are at risk being misinterpreted and mistreated due to inadequate linguistic and cultural services, resulting in the client not returning and further rejecting services due to cumulative negative experiences. Government and social agencies translate information and documents for only the largest minority groups, which are Spanish, Mandarin, Vietnamese, Haitian Creole, Khmer, and Portuguese. However, all but Spanish are typically geographically specific. Thus, Mandarin Cantonese may be available in the Chinatown, Boston area, but they may not be in Framingham. In Khmer may be available in Lowell, but may not be in Fall River. And all these are places where these subpopulations live. With only 3 Asian languages translated and an extensive number of LEP Asian victims are left without access to basic information on services and rights. English-only websites are impossible to navigate without a translator, and websites are translated with versions that are grossly inadequate. Agencies hiring fee-for-service translation interpreters on phone services are often hiring translation interpreter phone services on a case-by-case basis. The problem is the Asian LEP victims of violence have ongoing case management needs and multidisciplinary services. These require long-term care and support, provider engagement, education and coaching on the system, and off-site accompaniment. The problem is that it's not cost-effective and can be budget-breaking for mainstream providers. Consequently, providers may forego linguistic services to save costs and utilize services which are subpar, not trauma-informed, or inappropriate, resulting in clients being denied restraining orders, misinterpreted as perpetrators, arrested, losing custody of their children, less able to successfully assert legal claims and defend against legal accusation, and being denied or terminated from shelters. These are all very common, and we see it all the time. Asian interpreter pools are small and untrained. The problem is that small interpreter pools result in delayed court cases, wrong dialects being used, and ATASC advocates often being stand-ins. Lastly, unqualified employers are hiring linguistically and culturally specific staff. The problem is that employers without expertise to vet qualified, linguistically and culturally competent employees are unbeknownst hiring unqualified staff or volunteers who are then providing inadequate or sometimes detrimental services, interventions, and information to LEP consumers. So Boston is a home and part of life for many Asian Americans. A significant Asian population lives in the Boston area and neighborhoods. Even more receive services in Boston, even though they've been displaced due to gentrification. And many Asians identify with the neighborhoods in Boston, such as Chinatown, and Dorchester, as cultural hubs.
Thank you, Dawn.
Yeah.
Just if you can conclude it right now.
Yeah,
just
okay,
go
I will
over,
conclude it with this.
Another sentence or two.
Okay, so we need to develop culturally and linguistically competent services for a highly diverse population in Boston. This requires government agency and mainstream organizations to closely collaborate with culturally specific organizations and communities to best identify practice and policy.
Thank you very much. Appreciate it. A. Rachel Miller is next, followed by Anna Leslie. And for all of those who have prepared testimony, if you want to email me or email the committee, I'll make sure that all of our colleagues get copies. Or you could give it to Cora. So, A. Rachel is next, followed by Anna. Thank you for waiting.
Good morning, how are you? My name is Orisha Miller. I work at Berkeley College of Music as a chef, but I came with Chin Chi for healthcare disparities. I'm here to seek assistance for a family member who's been terrorized by sexual assault and violence towards her children. The first assault was on a 4-year-old child who was sent to the bathroom at her school by herself and was sexually molested, and nothing had happened, even though it happened 3 years ago. Nothing had happened with the school, with the attorneys, or the police officers, or the doctors. And the second assault happened to her 17-year-old child this year. She was getting raped by 5 guys. And so now this mother is at her wit's end and things of that nature. And the person who was trying to help her just had died last week. And so I'm trying to see if somebody is able to help her. So that's why I'm here.
Okay. Have you reached out to Boston Police?
They know. Boston Police know about both assaults.
Okay. Well, I'm very sorry to hear this, and we want to be helpful. This isn't the right forum to address that, but we can certainly make sure, if you want to stick around when we conclude this hearing.
Thank you.
We'll talk to you.
Yeah,
and
I
make
didn't
sure
come here
that
to
you
talk,
get the
but somebody
resources.
asked me to talk, and I said no at first because that wasn't on my mind. But since I'm here, that's why I brought it up.
No, thank you. If you don't mind waiting, we're nearly done.
problem.
We have 1 or 2
Thank
more
you.
speakers, and we'll talk to you after. Thank you very much for sharing that. Anna Leslie is next, and our final speaker, at least who's indicated they've signed up, is Chioma Nyaj. Anna and Chioma.
Hello. Hi, thank you for having me. I'm Anna Leslie. I'm the director of the Alston Brighton Health Collaborative. And I just wanted to reflect on the panel, and I think the discussion generally has been majority about downstream approaches and kind of reactive and less preventative work around the full spectrum of the social determinants. And so when you think about social determinants, I'm thinking transportation and housing infrastructure and education. And so I'd really love to see these future conversations include the Transportation Department and BPDA and BPS and the Zoning Board, because those are the things that really initially impact who is able to survive in our communities and thrive in our communities. Many of the things that we're talking about are in reaction to not having equitable access to services, and those things begin with transportation and housing and infrastructure and education. So I really think those departments really need to be integral to these conversations and to understand that that is a part of their work. I think they, at this point, see that work as very siloed and disconnected to their focus. And so a lot falls onto the public health department and public health sector to do reactive work to what is very much within their control, and they have abundant resources in a lot of cases to address these upstream strategies. So I'd really love to see that conversation expand and to put more of the onus on those departments with those resources. Thank you.
Thank you very much, Anna. Appreciate it. Chioma?
Good morning. Thank you for holding this meeting. My name is Chioma Nnaji. I'm a first-generation Nigerian. I moved to Boston 20 years ago to do my Master's of Public Health. Have lived here ever since, being committed to addressing the inequities as it relates to health disparities in communities of color. Currently, I'm a public health advocate, organizer, and I serve as a director at the Multicultural AIDS Coalition, which is a grassroots organization in South Boston, particularly focused on mobilizing communities of color to end the HIV epidemic. I'm here to talk about and bring to light the issues that African immigrants are dealing with here in the city of Boston. I see my work as being able to lift these voices and talk about how there's a need, when we talk about communities of color, that we're inclusive, at the same time talking about solidarity work, and at the same time addressing unique issues. So as many of you might know, because African immigrants live in you all's neighborhoods, African immigrants are one of the most fastest growing immigrant populations on a rapidly growing segment of the Black community in Boston. They migrate for work, educational opportunities, reunite with family, families and as asylees and refugees. These communities have historical ties to Boston, similar to such as Cape Verdeans who live in Upman Corner. They are longstanding refugee communities such as Somalis and Sudanese living in Roxbury and Jamaica Plain, and they are newer groups seeking asylum from countries such as the DR and Rwanda, living in various Boston cities. With owning businesses, being a part of the labor force, and hosting local cultural activities, African immigrants bring strengths of resiliency, economic growth, and cultural diversity. This community also faces multiple challenges when accessing, utilizing, and retaining in care due to barriers such as low health literacy, lack of health insurance, limited English proficiency, barriers related to patient and doctor communication, risk of disclosing immigration status, and a host of others related to navigating the healthcare system. As a result, African immigrants tend to be slow to seek health care and may present with relatively advanced health problems that need critical clinical interventions, increasing health care costs. Healthcare providers and systems that are not culturally and linguistically competent reinforce these challenges. Public safety and health policies that lead to housing displacement, anti-immigration policies such as public charge, institutional racism, food insecurity, and other determinants of health prove to compound our public health disparities addressing African immigrants. As such, I want to talk about 3 recommendations that I would like to respectfully offer to the Council. Greater attention must be paid to address public health disparities. And we can learn a lot from a lot of the other immigrant populations and communities in terms of what they have done. There's opportunities for solidarity work. I want to honor and respect and say thank you to Chin Chi, who is a peer colleague of mine who actually told me about this forum. And so there are ways in which we can work together for the same cause. So my first recommendation to the committee and the council is one, that we continue to support efforts such as the bill H26A1 that notes data desegregation as critical to identifying the public health disparities experienced by populations. Similar to Asian Americans, African Americans are grouped under the racial category as Black/African American, and because of this, we often miss the unique issues that African immigrants are dealing with and also the unique opportunities to reduce health disparities in that community. Number 2, I want to recommend that a body is dedicated to represent African immigrants, a body that is a part of the city's efforts through African Caucus or a commission. This permanent body would support understanding emerging issues, creating pathways to civic engagement, and making recommendations on how to improve the quality of life for this growing population. This has been proven effective in other immigrant communities here in Boston and has also been seen in other metropolitan areas, such as Washington, D.C. has a Mayor's Office of African Affairs, and the Bronx has an African Advisory Council. And my last recommendation is that we need to provide quality and culturally appropriate language access. It's critical to ensuring our most vulnerable communities, such as African immigrants, are able to receive, understand, and act on public health information. There's a need, I'm requesting to conduct a language access assessment and planning process for critical health-related programs under the City of Boston, such as youth and families, food access, fair housing, and emergency preparedness. This will provide an opportunity to expand language access to include languages most spoken by the African immigrant communities in Boston. I'll offer myself as a resource to each and every one of you as we continue to think about how we can better address public health disparities and particularly look at what is happening within African immigrant communities. Thank you.
Thank you very much. Appreciate your time and your testimony. That is all I have for public testimony, unless there is any individual that didn't sign up and would now like to speak. Going once, going twice. Well, this concludes the hearing. Thank you again to the makers, Councilor Ed Flynn and Councilor Kim Janey. Thank you to Council President Andrea Campbell and Councilor Lydia Edwards for their joining us in support of this initiative today. We now conclude docket number 1054. And again, Ms. Miller, if you could maybe afterwards just come down and we can talk privately, that would be helpful. All right, this hearing of the Committee on Healthy Women, Families, and Communities is hereby adjourned. Thank you all.